Hello doctors, I'm your mad buddy Arun and I welcome you to the continuation of third lecture which is on streptococcal diseases. This lecture is part of diseases caused by gram-positive bacteria. This lecture today is devoted to bacteria in Lancefield group A, the most medically important bacteria, that is Streptococcus pyogenes. It is pus-forming, abscess-forming that can be capsulated and uncapsulated. While capsule does not play an important role in virulence, because we have seen there are some strains of this bacteria which are not capsulated, such as strain 4 and strain 22, and still they cause pharyngitis with equal severity. The capsulated colonies appears smooth and mucoid on blood agar. The capsule carry hyaluronic acid which can bind to epithelial cells. The polysaccharide of capsule has affinity for CD44 T cells. These two factors are specific to pharyngitis, where we will see infected white layer and papules rising from that layer. These bacteria contain M protein in its cell wall, which has affinity for blood proteins, and because of this the bacteria gets surrounded by blood proteins and it can easily prevent phagocytosis and opsonization. We have extracted and isolated the M protein by acid extraction method, and this M protein then we combine with group A specific antisera which form clumps, and there is confirmation that this bacteria belongs to Lancefield group A. The EMM amplification has led to around 200 strains of this bacteria, which data is present in CDC, that is Center for Drug Control. It is responsible for acute rheumatic fever and post-streptococcal glomerulonephritis and many other pathologies. Pathogenesis. This bacteria carry streptolysin S and O, which directly damage the cell membrane and also causes hemolysis. It carries and secretes streptokinase, DNase, spice-sep protein molecules, serine protease, which all together reduce the effect of chemoattractants like cytokine and interleukins, and this further reduces the chemotaxis of neutrophils. It secretes pyogenic exotoxin, which is responsible for fever and rashes. The specific kind of rashes that are gritty rashes, feels like sand on touching, that is called scarlet fever. It leads to increase in cytokine number, which further can lead to streptococcal toxic shock syndrome. For its diagnosis, basically when there is confirmation of acute rheumatic fever or glomerulonephritis, then we want to confirm that is it streptococcal associated or no. Then we take the sample and then we check for streptolysin O and DNase by using specific antibody sera. Now the clinical features and treatment. First of all, it causes very commonly the pharyngitis. Pharyngitis in children above 3 years of age. More than 40% cases of sore throat is because of Strep pyogenes. It can also be associated with Strep aureus and other bacteria that should be ruled out, but mostly up to 40% it is associated with Strep pyogenes. It has specific features such as suppurative pharyngitis, which is white layer appearance in the pharynx where rising papules can be seen. There is malaise, fever, sore throat. The person feels very uncomfortable while swallowing. Scarlet fever. It is pharyngitis plus strawberry tongue appearance and gritty rash. It is due to specific production of exotoxin. When suspected scarlet fever, other diagnoses also should be ruled out, such as Kawasaki's disease, systemic allergies, toxic shock syndromes, drug reactions, that is impetigo, also called as pyoderma. It can be caused by both S. aureus and Streptococcus pyogenes. There is some difference in these clinical features. That is, when it is caused by S. aureus, there is formation of thin paper-like crust on the skin surface. It is limited to only skin invasion, that is surface invasion. In Streptococcus pyogen, there are formation of thick bullae-like structure on skin surface, and this is associated with poor hygiene, insect bite, which can inoculate the Streptococcus pyogenes within the skin. There are vesicular and pustular lesions which are specific. First of all, in early stage there will be vesicular and pustular lesion which will later break down into honeycomb-like structure. When there is impetigo and such condition of skin, it gives free invitations to other pathogens, and there is no surprise that these two bacteria can together be infecting the same surface. It can be confused with herpetic lesion, that is a viral infection, but there is a little difference. That is, the herpetic lesions are more discrete and grouped. And for confirmation, we can do this test, which is called Zank test. The test can be included like culture. This is generally non-painful and fever is not associated with this. It is generally visible on skin, nose and legs. Colitis. It is associated with wound or infection occurring in surgical ward within 24 hours. It can be associated with insect bite. These are bright red, shiny, swollen, tender facial skin. It is called erysipelas, which is associated with fever and chills also. There are no typical signs of cellulitis. We can only see certain kind of redness, rashes, so confirmatory test should be ruled out. We can see lymphangitis, that is, from the site of infection, it will involve the lymphatic drainage, and when inflammation in the lymphatic vessels will be there, then there will be visible parallel line or lines moving from the site of infection and moving far from the site of infection. It is called lymphangitis, and it is mainly associated with when there is lymphatic disruption. It can also be associated with group C, group G and Staph aureus. It is not very specific to Streptococcus pyogenes. It can be associated with other bacteria. Necrotizingfacitis and myositis. These both are surgical emergencies which require surgical drainage of the muscle that is involved and surgical removal of the fascia with emergency administration of antibiotics. Necrotizingfacitis is infection of fascia which has features like the trauma was on the hand, the surgery was performed on the hand, but inflammation occurred on the chest muscle. due to the same fascia on arm and chest muscle. It can be associated with pneumonia and empyema. The empyema again is a surgical emergency which requires drainage of pleura. Pneumonia, that is sudden onset pneumonia, is there in Streptococcus pyogen pneumonia. Pneumonia is also caused by other bacteria, but in case of Streptococcal pyogen there is sudden onset of pneumonia. Sudden onset of features such as purulent sputum, fever, chills can be associated with Streptococcus pyogenes. It can lead to septic shock syndrome, that is streptococcal septic shock, which is deadly. It can lead to bacteremia, which can further lead to seeding complications such as septic arthritis, endocarditis. Now the treatment. For treatment of pharyngitis, penicillin G 1.2 million units. Cephalosporin and macrolides can be the alternative, and for oral penicillin V can be given. In children, 600,000 million units have to be given, which have a weight lower than 27 kgs. For impetigo, the same regime has to be followed. For cellulitis, again the same regime has to be followed. For necrotizingfacitis, surgical drainage, penicillin plus clindamycin. In this case, the penicillin dosage will be double, that is 2.4 million units IV. For pneumonia and empyema, again the penicillin dose will be doubled, and if it is empyema, then surgical drainage. Streptococcal toxic shock syndrome, penicillin double the dosage, 2.4 million unit IV plus clindamycin 600 to 900 mg IV plus IV immunoglobulins 2 gram per kg. A single dose has to be given.